to your toe and flow model.
Uh-huh.
Um, this came in and it really just looked like a carbuncle. So
Yeah.
initially, so I drained the carbuncle,
Yeah.
and then this ensued, and it grew out a mixed bug, and
Uh-huh.
I had put this patient empirically on omadacycline
Uh-huh.
and granulation, but it looked as if there was like also a little bit of fat, the underlying fat underneath the dermis.
Uh-huh. Yeah.
Anyway,
Uh, well, I mean, so let me ask you,
it's only
uh,
about 2 by 2 centimeters, so it's not a large wound,
yeah,
but it
I think if you're concerned about the wound, I mean, you can obviously get a biopsy of the thing if you're concerned about the way it's looking. That's something that we probably don't do enough collectively.
and the
Um,
pulses were not good. I should have told you that. The pulse
okay.
non palpable pulses, and there was this picture I showed you. He had more swelling prior to the picture that I just showed you. So what would your next set of steps be in your hands? What do you generally do with that?
Yeah, obviously, this is the kind of thing where I'd get non-invasive vascular studies, and I'd also at the same time call my flow migo, who's right across the hall from me, right? And so we have these kind of forced curbsides, and it's just great because we can have him or her, in the room.
Yeah. So that's exactly what ended up happening is that it was on the venous side. I had sent for ABIs because I couldn't feel the pulses, and they said, yeah, we're probably going to examine the venous, and that's what they did. Um, and so I'll try to put this as close as I can. This is the diagram he sent me
Yeah,
back. So all three of those vessels, the greater saphenous and the lesser saphenous and accessory saphenous, were not optimum.
yeah,
And do you see a lot of that where you're in your clinic where you're having to have venous ablations to get the deeper vessels to do their job to get
yeah.
the
That's pretty awesome. It's not common. We definitely see it, but it's not common on the foot. But we usually obviously we are used to seeing that, in the so-called gator area of the leg, or even laterally on the leg. And we see obviously so many venous leg ulcers right now. I just saw on Tuesday that definitely has both diabetic foot, it's mixed etiology, DFU and VLU, and so those are definitely ways forward. And uh, uh, we definitely will have that patient assessed for benefit for venous ablation. And because the data are actually pretty strong for venous leg ulcers, for healing and also for recurrence, that if a patient has a something that is um, incompetent and that can be and she or he is a good candidate, that endovenous ablation can be really valuable. It can be very, very, and I think a lot of times, we end up nursing these wounds um, when we should be doctoring them as well as nursing them, right? And so this is one of those kind of situations.